Hi, this is Andrew Wolf, and in this video I'm going to provide an overview of the pathophysiology of COPD, otherwise known as chronic obstructive pulmonary disease. Now, this is actually sort of a syndrome made up of a couple of different diseases, and the diseases are chronic bronchitis and emphysema. Now, these are sort of thought of as two separate diseases, but they oftentimes overlap. So patients with COPD may have just chronic bronchitis, they may have just emphysema, or they may have both. Some being a little bit more emphysematous, but with significant chronic bronchitis, and others with primarily chronic bronchitis with a little bit of emphysematous disease. Now, their pathophysiology, actually their pathogenesis is a little bit different, but they both end up with the same symptoms because, and that's not surprising because they both end up causing obstruction of the bronchioles, which are, particularly the respiratory bronchioles just prior to meeting the alveoli. Now, before we get started, I wanted to talk a little bit about how the airway stays open in healthy lungs. So here we have, a patient's trachea, and got the carina here, and it bifurcates off, and eventually we work our way all the way down to bronchioles, and I'm skipping obviously many generations. Now here, let me open one up here, and we'll put another alveoli here, and obviously this is a very rough, this is just a diagram of the respiratory system. This obviously isn't an anatomically correct map. Now, generally the trachea and the large bronchi are covered with these pseudocolumnar, pseudostratified columnar epithelium, and interspersed with these little goblet cells. And every few cells there's a goblet cell, and the ciliated pseudocolumnar epithelium have on top of them cilia, hence the name. And the cilia are always beating. So got the cilia here, and we have the goblet cells continually secreting mucus to such a degree that there is a blanket, an uninterrupted blanket of mucus that covers the trachea from top to bottom. Okay, and this is obviously there is room for airway here as well, and in a healthy person. And with a healthy person, this mucus is constantly being beat by the cilia up to the top of the airway and down the esophagus. So much so remember, we create about 1 liter per day, if you've watched my previous videos. About 1 liter per day, and we swallow it without even noticing it. But what happens with smokers is they end up losing their cilia because of their smoking, and actually there's more changes to these cells that occur. They are no longer, they actually start to develop a stratified squamous epithelium, and they're no longer, and they also, as part of that, they lose their cilia. So, and the goblet cells actually begin hypersecreting. So we end up with this very thick layer of mucus that is not being removed. So it's no longer being removed. So what do smokers do to remove it? Well, they're constantly hacking and coughing because we've got mucus that is just static inside the airways. And there's parts of the airways, particularly the carina and some other areas, that when there's a lot of mucus around, they get irritated and it causes a cough. So with smokers, we end up with a cough to try to remove that secretion, right? But also, these cilia all the way down into the bronchi are important for removing the mucus that's being created even in the small bronchi. So what happens with one thing that happens is mucus starts to build up in the small airways as well as the large airways. So we get tons of mucus. And when we have lots of mucus building up and no way to remove it, because we have no cilia on our epithelium, this sort of chronically gets infected and causes bronchitis, so repeated bouts of bacterial bronchitis. And this makes matters worse because it increases the inflammation, the chronic inflammation of our airways. So we end up with chronic inflammation. Okay. And then this becomes a vicious cycle where the inflammation is causing increased buildup of the mucus. That causes more bronchitis, and the situation just continues to spiral and get worse and worse. Now, in a healthy person's lung, remember all this stuff is getting removed, so we don't get a buildup down in the tissues here. But with patients with COPD, you have this chronic buildup of mucus, and this causes obstruction in the airway. So the air gets stuck in the alveoli. Okay, so here, let me use blue here. So we have air that gets stuck in the alveoli, and that is because the air is travels easier on inspiration than it does on expiration. Why does that occur? Well, if you think about the way the lungs work, all the airways in the lungs are sort of tethered together by collagen and elastin, actually more elastin than collagen. And eventually they're going to be tethered to the pleura. And when we take a breath in, we pull outwards on the pleura, and when we pull outwards on the pleura, this force is also pulling outwards on the airways. Now these airways are very thin-walled, floppy little things. There's no cartilage in them. If we cut one out and put it on a tabletop, let's pretend we cut one out and put it on a little tiny table, it wouldn't stay open like that. It would just flatten immediately because it has no structure. So it is dependent on these elastin fibers and collagen fibers to be sort of pulled open, and this is called tethering. So they are being held open by the forces within the lung. So on inspiration, they open a little further, right? So on inspiration, the airways open, and on expiration, they don't close completely, but they may flatten up a little bit because the forces are not quite as strong, right? Because we still have some elastin. The elasticity of the lungs still can pull them open a little bit. So that is why we get more obstruction on expiration than inspiration. So expiration, obstruction is greater than inspiration obstruction. And that's why we get air trapping. Okay? So that leads to air trapping. Whoops. I'm not going to be able to see that very well. So again, what happens is on inspiration, the airway gets pulled open, and even when there is mucus present, it can it opens up enough for the air to get past, right? You know, and it fills up the alveoli. But then what happens on expiration is this force dissipates a little bit. So I'm going to make shorter arrows to show that this is just force from elastin. Here, let me do that a little bit better. Make a little short zigzag so you can sort of picture these elastin fibers have shortened up, right? And then now the mucus is blocking the entire tube, so the air that came in has nowhere to go, right? Can't get out. And then what happens? What happens on the next breath? Well, on the next breath, it opens up again, and more air comes in, and you end up with overdistension. This happens over and over again, and eventually you're going to end up with big, huge, boggy alveoli that are wide open and filled with air. So that's what's causing the obstruction. And this here, the condition caused by this chronic inflammation and mucus secretion, is chronic bronchitis, right? So what is emphysema? Well, emphysema is actually damage to the collagen and elastin fibers between the airways. So it's kind of an interference with the structural integrity of the lungs. And if you imagine that you're losing elastin and collagen, you're interfering with this tethering effect. In this tethering effect, remember, because the elastin fibers is really important in keeping the airway open both on inspiration and expiration. So if you imagine, you shorten these up even more because these elastin fibers are problematic. Even if there is no mucus here, what happens with emphysema is the airways just don't open, period, because you have this elastin that is so small. Here, it just isn't strong enough to open the airway. Okay, so you end up with an airway that is closed up almost completely on expiration. Now again, remember, on inspiration, because there is some negative inspiratory force pulling on the fibers that are there, it's able to pull it open. But on expiration, the airway is going to close completely. So just to review, chronic bronchitis is a disease of mucus hypersecretion, and decreased mucus clearance that causes obstruction. And emphysema is a disease of lung fibrosis and loss of elastic recoil. So the elastin fibers are sort of destroyed and replaced by scar tissue. Okay, so here I just want to say the sort of technical term for this is loss of mucus for chronic bronchitis is loss of mucociliary clearance. So that's sort of the technical term. Mucociliary clearance. Okay, so that's the pathophysiology of these two diseases in a nutshell. Now, again, there are many people that have symptoms of both chronic bronchitis and emphysema. So they may have some lung fibrosis with loss of elastic recoil in addition to mucus hypersecretion and decreased clearance. And I would say the majority of people with COPD have some degree of both. Okay, so I wanted to talk a little bit about what you observe clinically with COPD. So COPD is characterized by three things. First, it's characterized by progressive dyspnea. Remember, I talked about dyspnea in an earlier slide. If you haven't seen my dyspnea video, please go back and review this dyspnea video. Dyspnea is, in short, I talk about how dyspnea is a very complex constellation of symptoms. It's not just shortness of breath. It is characterized by a number of things. And patients with COPD become dyspneic because we are interfering with their gas exchange in the alveoli, and you end up with air trapping, and this air, as it's trapped in here, it begins to have very low levels of oxygen and very high levels of CO2, and this begins to be reflected in the blood with hypercapnia and hypoxemia. Now, the hypercapnia and hypoxemia are detected by the chemoreceptors, both in our brainstem as well as our peripheral chemoreceptors in our carotid bodies and aortic bodies, and these send messages up to our brain, to the respiratory center in our brain, to breathe faster and deeper. So we are going to have a sensation of increased work of breathing and rate, and that's part of dyspnea. And also, at some point, no matter how many messages our receptors are sending up to our brain, we're not going to be able to keep up. So we are going to sort of have an unmet need. We're going to be hypoxic, but not really be able to respond effectively to it. So the hypoxemia itself and hypercapnia itself will cause a sensation of air hunger. Okay, air hunger, and that is part of the sensation of dyspnea. And there's some other things involved, but those are probably the major parts that cause this. Now, so this explains the dyspnea. Now, why is it progressive? Well, I sort of hinted at in the prior setting how emphysema, both emphysema and chronic bronchitis, cause injury and inflammation to the lungs. And that results in sort of this positive feedback loop where the inflammation of the increased mucus and the injury of sort of the stretching of the alveoli causes more inflammation, and that inflammation makes more increased mucus secretion and a bronchiolar wall thickening and fibrosis of the lungs. Okay, and that makes the inflammation worse, and you end up with this downward spiral. So what is it that makes inflammation worse? Well, it's the presence of chronic secretions, and these chronic secretions are filled with white blood cells and inflammatory mediators, and the air trapping itself causes injury. So we end up with more inflammation and fibrosis, lung fibrosis. So even without added insult, this is going to be a progressive condition because of this downward spiral. So how do we prevent this? How do we slow this downward spiral? We actually haven't figured out how to reverse it, but we can slow it, and the way to slow it is to stop the inflammation, right? So it's inflammation that is driving this downward spiral. So the treatments that we use to try to stop the inflammation is to give steroids, and this is only partially effective. And tends to affect symptoms more than the progression of the disease. But the thing that helps the most at preventing at slowing this downward spiral is to stop the initial insult, which is in over 90% of the cases smoking, because this is driving the initial inflammation even more than the ongoing disease. Okay, so what is the second symptom in this clinical syndrome? It is a chronic cough. Now, chronic bronchitis causes a cough because of the irritation of mucus present in the airways and the inflammation. Now, emphysema also has elements of inflammation as well, because it's a central component of both diseases. But emphysema also causes a chronic cough because of stretch receptors. Okay, and then the third element that sort of completes the picture is a history of chronic tobacco use, and I talked about that above. And so if you have a patient with progressive dyspnea that has been getting worse over time, and a chronic cough, and chronic tobacco use, then your first diagnosis on your differential list should be chronic obstructive pulmonary disease. This does not diagnose chronic obstructive pulmonary disease because there are other conditions that can cause progressive dyspnea, chronic cough, and chronic tobacco use, but this is the most common. Okay, so I wanted to talk a little bit about how we work up COPD and the pathophysiology behind that, the sort of pathophysiological theory behind this workup. So COPD workup. In order to diagnose COPD, we need pulmonary function tests. Function tests, otherwise known as PFTs. Why is that? Because COPD is a group of diseases characterized by chronic obstruction of the airways. So how do we know that they are chronically obstructed? Well, what we do is we measure the PFTs. Now, the pulmonary function tests are testing flow and volume when we breathe. And there's a couple of tests that we are particularly interested within the pulmonary function tests. Pulmonary function tests incorporate a number of tests of inspiratory and expiratory volumes and capacities. And we are most interested in a test called the forced expiratory volume over 1 second. And this is abbreviated as a FEV1. And then the other test that we also look at is a forced vital capacity, abbreviated as FVC. Now, with a normal lung, this here is volume, and this means time, 1 second, 2 seconds, 3 seconds, 4 seconds. This is volume, 1 liter, 2 liters, 3 liters, 4 liters, 5 liters. Now, a normal healthy lung, if you ask a person to breathe out as fast as they can and as hard as they can after a deep inspiration, their flow volume curve is going to look like this. Whoops, that wasn't right. Let's see if I can get that better. So they're going to breathe out, about 4 liters in about 1 second. So their FEV1 will be 4 liters. And their FVC will be their total the total volume. See, this starts to plateau up here, so they're not breathing out anymore after about 4 seconds. So their forced vital capacity is going to be about 5 liters. And then you can measure what's called the FEV1 over FVC ratio, and in this case it would be about 0.8, which is okay. Now, with a person with COPD, whether they have chronic bronchitis or emphysema, it doesn't matter. We're measuring obstruction here. Their curve is going to look more like this. And that's just a rough drawing, but you can see here, well, this person's FEV1 is terrible. So the FEV1 here for this person with obstruction is going to be about 1 liter. But the FVC is decreased, but not quite as much as the FEV1. So the forced vital capacity is going to be about 4 liters. Now, the FEV1 over FVC ratio is going to be about 0.25, which is horrible. And that's just because of the way that I drew the graph. But anyways, you can see that this person, the healthy person, as they breathe out as fast as they can, breathes out the majority of their volume in the first second. But this person with COPD, they breathe out as hard as fast as they can, but they only get out 25% of their volume, total volume, in the first second. So this suggests significant obstruction. And this is the test. If you can demonstrate obstruction on these PFTs, and you have a person that has progressive dyspnea, chronic cough, and a smoking history, then you have diagnosed COPD, because you have shown that the person has obstruction. Okay, this ends my brief introduction to chronic obstructive pulmonary disease. I hope you've enjoyed the video. Please take a moment to rate the video with a thumbs up or a thumbs down, and feel free to leave me a comment. I always appreciate that, and also feel free to write a question, and I will be glad to try to answer it. Thank you very much.